Hello everyone, I'm Dr. Pallavi from Head Neck Surgery. Today on the day of World Cancer Day, with the theme of Close the Care Gap, we are here to discuss about the basic questions from patients regarding cancer, especially head and neck cancer. So here we have Dr. Vidya Bhushan. He's from the Head and Neck Surgical Oncology team and specialized in skull-based surgery. And Dr. Saurabh, he's from the head of the Department of Radiation Oncology from Mazumdar Shaw Cancer Center. Sir, I would like to ask you a few questions on the basic question which is head and neck cancer. What is head and neck cancer actually?
Hi everyone. So head and neck cancer is the cancer which arises from various sites in our head and neck, like thyroid cancer, laryngeal cancer, pharynx cancer, the oral cavity, mouth cancer as it is commonly known as.
Okay. So, sir, how common is it? Like, what all types of cancer do we commonly see?
Yeah, so if you see the statistics for Karnataka, or if you see the statistics as such in India, right now, probably after breast cancer and cervical cancer, the third most common cancer in the top 10 list would be, top 3 itself is head and neck cancer. So again, in head and neck cancer, it's like a various array of cancers. To start with, most commonly in India, because of the habits and all that, buccal mucosa and oral tongue, the cheek cancers and the cancer of the tongue are most common. Thyroid cancers are also quite common. And other cancers like cancers of the skin, of the face, cancer of the orbit, cancer of nasal cavity, cancers of the sinuses, cancers of the salivary glands. All these are also there, but they form a small component of the head and neck cancer.
Okay. And what are generally the most common causes for head and neck cancer?
Yeah. Among all the head and neck cancers, the most common site of cancer is the oral cavity. And like my colleague Dr. Saurabh told, there are various other sites where cancer can occur. But the most common site in head and neck is the oral cancer. Now, in our population, if you see, the most common cause for oral cancer is tobacco. Like you know, tobacco can be used in smokeless form or in the cigarette form. Apart from tobacco, various other etiologies, various other causes for cancer are alcohol consumption, and there are very other chemicals like lead and everything which have been instigated as a cause in sinonasal cancers. If we talk about skin cancer in head and neck, exposure to ultraviolet rays, those are one of the causes of skin cancer. But in general, the most common culprit is tobacco. That is the most common cause of oral cancer.
So the patients generally ask that, is it possible that even with no habits, cancer, there are any cases of cancer?
Yeah, so without the usage of tobacco or alcohol also, cancers are known to occur. So those will be sporadic cases because of spontaneous genetic mutation. Okay, so it doesn't mean that only if you are a user of tobacco or alcohol you will get cancer. So with the spontaneous genetic mutation, cancers are known to occur. Like suppose it might be any cancer. It can be a thyroid cancer, it can be oral cavity cancer, or sinonasal cancer, which are occupational related.
They even ask that, is it like possible that if their mother has, then is it possible that they will have it as well? So family history.
Yes. So family history is very important. So if we look at the literature, the incidence of cancer, if in a first degree relative with the habitual user, rises almost up to 10 to 20 times if the person is addicted to any habits. Without any habits, the genetic predisposition or the genetic penetration roughly varies around 5 to 10%.
Okay.
So basically, it is not a commonly something which head and neck cancer as such is not genetically you can clearly say that it is not transmittable from generation to generation. It is more of either habits. Or some chronic irritation, like a tooth or chronic tooth infection or something which is irritating the buccal mucosa constantly. This is what will lead to cancer, probably not as such as a genetic predisposition. Oral cavity cancers are not so common. What about thyroid cancer, Bhushan?
So thyroid cancers, again, spontaneous genetic mutation. And another factor which has been explained is exposure to radiation in a younger age group, like supposed to be maybe getting multiple scans done in the fetal age group or in the early adolescent group predisposes them to develop thyroid cancer. And there are specific occupational thing also, like I told, working in a chemical industry, like a lead industry, it is implicated in a sinonasal cancer.
Nickel.
Yes. And wood is particularly indicated in a specific minor salivary gland tumors in the sinonasal region.
So basically this is chronic irritation.
Yes, kind of.
So chronic irritation of any sort, it's something very similar to a denture or a tooth which is chronically misused.
Yes,
and,
yes.
It happens.
So what are the symptoms which patients have to watch out and then come to show it, basically?
Yeah. So symptoms wise, most commonly what we come across is a non-healing ulcer. There is a small ulcer or something which is not healing repeatedly, and basic medications are already been tried multiple times, and it is growing in spite of that. One most important thing is, lot of times these are painless ulcers, and which is growing, and even in spite of repeated antibiotics or any form of treatment, still the patient comes back saying that it is a non-healing ulcer. Sometimes even they go with some referred pain like ear pain, which is also not getting corrected. Quite a lot of times we see that they have gone to dentist multiple times for a tooth decay or a gum infection, which is not getting corrected. And then when you examine, you see that there are a lot of patients who come with a neck swelling. They don't see anything in the oral cavity, but they come with some neck swelling which has been ruled out for TB, which has been ruled out for any infection. They can't find why there is a neck swelling. And that neck swelling is growing over a period of time. These are the most common way how the patient comes to us and presents to us. Anything else you want to add, Bhushan?
Yeah, like you told, it depends on the site of involvement. Like Dr. Saurabh told, if it's in the oral cavity non-healing ulcer, if it's in other sites, suppose if it's in the nose, patients will come with the bleeding from the nose, or they might have a nose block. Particularly, we have seen few patients where the sleeping partner identifies that there will be recent onset of excessive snoring.
Yeah.
So, which will indicate a tumor in the nose, which will cause airway issues.
Repeated bleedings.
Yes.
So how do you go about it, like for planning? Is it about the diagnosis? How do you go about it?
So, diagnosing a head and neck cancer is not all a big deal. Particularly the oral cancer is almost a self-diagnostic kind of thing. Patient himself can examine and comes to us with a non-healing ulceration. So for us to diagnose it as cancer, first thing what we do is we'll do something called a biopsy. Like we will take a small chunk of tissue from the growth and we send it for the laboratory for testing. So we'll get to know what type of cancer it is. So cancer itself, there are many types of cancer, whether it is a salivary gland tumor or whether it is a mucosal squamous cell carcinoma, because even the management varies. So first thing what we do is we do a biopsy. Suppose patient comes with a thyroid swelling. When we are suspecting thyroid tumor, we don't do a biopsy. We do a very small needle test called FNAC, and all these are daycare OPD basis procedure where report is also available in few hours of time. So biopsy to get a histological diagnosis is what is done. And then once we have the diagnosis of cancer, then we go ahead with the imaging. We'll do a CT scan to know what stage the tumor is in and where all it is spread to.
So patients even have that question that which scan, like sometimes they come with their own diagnosis that maybe PET scan is required. So how do you go about that scans?
So basically there is set guidelines as to what imaging has to be done. Imaging, most common imaging which we always see is CT scan, which is kind of sufficient for majority of the cases. PET scan is not a must in all head and neck cancer. There is a subset of patients where we would probably consider PET scan when it is locally advanced. Mainly PET scan gives us a holistic approach to get an idea whether the disease is just local or it has spread in anywhere else. Just for a local head and neck cancer, there is no need to do PET scan on a routine basis. Even a head and neck cancer, just a CT scan. And for any further information, probably an MRI is more than sufficient in majority of the cases. Sometimes even an ultrasound is also sufficient.
Okay. So then about treatment, like there's surgery, there's radiation, then there's chemotherapy. So how do you like plan it out?
Yeah. So again, to like you told, these are the three modalities of treatment we have: surgery, chemotherapy, and radiation. Which modality of treatment to be used depends on the site of tumor and the stage of tumor. Like suppose if we talk of oral cavity, then the standard of care is surgery followed by radiation or chemotherapy depending on the stage. If we talk of laryngeal tumors, there the standard of care for the early stage is radiation, that is organ preservation, and surgery if at all it is required. Only in advanced stages of laryngeal cancer we do offer surgeries. Otherwise, early stages it will be treated by radiation. Then if we take thyroid malignancies, the main modality of treatment is surgery followed by iodine ablation. If we talk of oropharyngeal tumors, like tumors of the base of tongue or tumors of the tonsil, again the main modality of treatment is chemotherapy with radiation.
So basically, one thing we need to understand is that each patient is special.
Yes.
All cases have to be discussed on an individual basis in tumor board. We should have case discussions with all the subspecialty, all the three people, the medical oncologist, the radiation oncologist, the surgical oncologist, as well as other teams like, speech and swallow, psychotherapy. All these people have to come together, sit, discuss, and make a plan for each and every patient. Like Bhushan said, we have set guidelines. Already there is standardization that you have to do surgery in an oral cavity cancer. Then if there are so many risk factors, you do radiation. If there is additional risk factors, you do some chemotherapy. So this is all standard. But for each and every patient, we have to again sit and discuss.
Yes.
So that we have a clarity on for each patient. It can change also. Sometimes some patient may not be fit for surgery. That time you have to offer them something. And maybe it is not the standard of care. Maybe it will not give the same outcome as you go for standard of care. But based on that outcome, we have to plan it out for the patient. And also you have to discuss with the patient because they also need to have a say on what they are going to undergo.
So, sir, there are patients who avoid radiation or surgery because of the side effects. So they want to ask if chemotherapy can be an option, or is it having any other?
Yeah, so I think of late there has been a trend towards that there are a lot of patients who come with only chemotherapy. They have taken chemotherapy for years together. But one thing you need to understand that may not be a cure. Either surgery or radiation in head and neck cancer based on the subsite gives a cure. Chemotherapy doesn't, in very few patients like lymphomas or very subset of patients is where chemotherapy alone can get cure. Radiation and surgery are the key pillars and chemotherapy adds to it. Before surgery or chemotherapy, only in a subset of patients, there has been some benefit to downstage the tumor to make it curable. But otherwise, as such, chemotherapy is given only as a palliative thing or to enhance the effect of surgery or radiation.
So we'll conclude the session now. Sir, is there any take-home message from your side?
Yeah. So not everything is very bad and not everything is very negative in treatment of cancer. So if cancer is detected in early stage, there is definitely a chance of cure. But very unfortunately, due to the lack of awareness, lack of accessibility to facilities, and due to fear, patients tend to avoid treatment and they tend to come at the very advanced stage. So what I would give a very positive note that with newer diagnostic modalities, newer surgical modalities, newer modalities with radiation, definitely cancer is curable if it is detected in an early stage. At the same time, giving a highest quality of life to the patient. See, treating is not the only thing. We should give back the quality of life, good quality of life, where even cancer patients need to go back to their work, need to earn for their family, need to socialize. Okay, so with best of modalities, the surgical modalities, radiation oncology modalities, and the newer immunotherapeutic drugs, definitely cancer is curable, and we can give them a good quality of life.
So you want to add something?
Yeah, so adding just to what Bhushan said, that everything today, what we have seen past 10 years, the things have changed a lot. The surgeons also, the advancement in surgery, we have somebody called a head and neck surgeon, which was not there. Previously there are cancer surgeons who would do everything. So today we have even in head and neck surgery, we have something called a skull-based surgeon. So it's gone into such subspecialization that even the outcomes are so different. Similarly, for radiation, the advancement is such that whatever we used to see in the past, the toxicity, the complications, what you had seen, they are not seen nowadays. The advancement is so different, and the outcomes are so different because of that. The quality of life has improved. Chemotherapy, no patient complains of vomiting nowadays, which was the fear in the past. So there is so much advancements in radiation, so much advancements in chemotherapy. Adding to that, already what outcome we are getting with a good surgery outcome, these things also complement in a better way. And at the end of the day, the patients have a better quality of life, better survival. And I think there should be no fear from the patient's point of view. There are ups and downs, there will be side effect, but at the end of the day, there is going to be a good sunshine. Thank you.
Thank you, everyone.
Thank you.